In the journey of life, we often face trials and tribulations that test our faith and resilience. But through every challenge, there is a guiding light. Revival of Hope Global Outreach Ministries proudly presents My Mess Became My Message, 7 p.m. by Dr. Michelle Ford. Dr. Michelle has transformed her life's challenges into a powerful message of hope and healing. Her mission is to create a safe space for women to find freedom, healing, and self-worth. Join Dr. Michelle on this transformative journey. Discover the power of faith, hope, and healing. Together, we can overcome any obstacle and embrace the future God has planned for us.
Press on, and to know that the God that we serve is the same today, the same yesterday, and He will be the same forever.
Welcome to our audience from wherever you're listening all over the world. Some of you are in the Philippines, some of you in Dominican Republic, some of you in Jamaica, some of you in Canada. And to our audience in the United States, welcome to the Revival Hope Global Outreach Ministry program presentation of My Mess Became My Message with our host and presenter, Dr. Michelle.
Welcome back. Thank you, Pastor Hobson, for that warm introduction. And My Mess Became My Message is a space where we break myths, spotlight healing, and explore what real wellness looks like. And as he said, I am your host, Dr. Michiel, and my co-host, Queenie. And today we are diving into a topic that is often misunderstood: speech therapy. As always, please let us know where you're tuning in from and just post today a word of affirmation, not how you're doing. Affirm yourself. So or put in the chat a word to affirm yourself and also others. Hey, Queenie, how are you?
Hi, doctor. I'm good. Thank you.
That's
I hope
good.
around the world is feeling as good as I am today. I'm so excited to discuss with you and learn more about speech language therapy from you.
Oh, yes. We are one hidden field that many people are not aware of until they need it. And that's just, I always say that we're not a sexy field. You know, nurses sexy, doctors are sexy, but you say, hey, I'm a speech therapy. Nah, you're just a speech therapist, right? But there's so much more that we do than just speech. And today I want to try to break some myth that is associated with our profession. And the title, what is speech therapy really? It's a question. What is it really? So I want you to put in the chat what you think speech therapy is. And I will go into what we do and then try to break down some of the myth of explaining what speech language pathologists actually do. And I am a proud speech pathologist for 24 years. I love my job. I love making a difference. And not only is it a job to me, it is a ministry. So now, when you hear speech therapy, quote unquote, what comes to mind? Drop that in the chat. So for most people, it's probably a kid trying to say R's and S's, right? While that's part of it, speech therapy is actually more. So let's go into what speech language pathologists really do. And I will refer to us as SLPs. And see, I'm wearing my little pin here. I am 3% SLP, and that means that only 3% Blacks are actually SLPs. So there's not a lot of us running around. So when you walk into a room and someone can relate to you, it sets them at ease. And why do our work really matter? We work with all ages of individuals, not only children. Because I know when we think about speech therapy, most people are thinking about kids. But there are two sides. You know, my friend, Dr. Denise was on. She does the pediatric aspect of speech, and I do the medical aspect. So I work with the geriatric population, and I like doing that. For to me, that's exciting. She likes doing pediatric because that's exciting. But nonetheless, every single speech pathologist that you know will let you know that their job is rewarding, is fulfilling, and we have fun doing it. So what is speech therapy? The assessment and treatment of communication problems. Not only just communication problems, we work on speech, we work on voice, work on cognition, and also swallowing disorders. So we cover a wide array of disorders. And it's usually provided by highly trained professionals. So pretty much we need our master's degree or our doctorate degree. If you have a bachelor's in speech therapy, more than likely you'll be working as a speech therapy assistant. And we work with all ages, from infants to seniors, to improve speaking, listening, understanding, reading, writing, social communication, and swallowing. And I mean, please free to drop any question in the chat, and I'll be more than willing to respond. And Queenie, you can jump anytime and ask questions as well. So I had 3 myths that I've heard when I walk into patients' room. And that is, speech therapy is only for kids. And I'll delve into those later, but I'm just going to highlight them right now. So speech therapy is only for kids. If you can talk, you don't need speech therapy. I walk into someone's room and they said, hey, I can talk. Why do I need a speech therapist? And then I'll have to explain all the different things that we do. And they say, oh yeah, it's my memory. And then another myth is speech language pathologists only work on speech. And that's also a myth. So there are 9 core areas of clinical practice that we focus on. And it's articulation, fluency, voice and resonance, receptive and expressive language, hearing, swallowing, that I will refer to as dysphagia. So that's a clinical term. Cognitive aspects of communication, social aspects of communication, and communication modalities, and that's augmentative and alternative communication. So that's when we introduce devices if we are unable to get someone to speak. So first, let's talk about articulation. And this is how clearly a person produces speech sounds. So when articulation is impaired, it can make speech hard to understand. So for example, a child says wabbit instead of rabbit, or omit sounds like saying ka instead of cat. And I'll give an example of that. My son, I'm a speech therapist, so I'm real picky when it comes to sounds. So my son, when he was about 3 years old, I think 3 or 4, somewhere around there, whenever he hurts his leg, he would say, my leg hurts. And I'm like, oh, no, sweetie, it's your leg hurts. And he said, yes, my leg hurts. So I'd say the same word to him. And I said, oh, your leg hurts? Because I wanted to know if he's able to decipher sounds. So I said, your leg hurts? And he said, no, my leg hurts. So he knew when I said it was the wrong thing, but it was the wrong sound that was coming out. I knew then he did not have a disorder, because if he did, he would have said, yes, my leg hurts, because that's the sound that he's hearing. So normally kids with disorder, they're not able to decipher the difference between the sounds. So that's the reason why a speech language pathologist would come in and help them with those sounds. And there's also includes issues with lisping. When my son was 2 years old, he had a lisp. Thank God we worked on that, and he's doing a whole lot better. Or mispronouncing sounds such as R or S. And those are 2 of the big sounds that are usually misarticulated in lisping. So what we do as SLPs, we help individuals learn the correct movements of the mouth. So for my son, when he had the lisp, I would tell him to keep the snake in the cage, which is your tongue. So you close your teeth, and produce that sound. And then also for different, tongue placement, like for t, we let them know like where they would feel that sound. It would be more in the palate. For like an F, we know, okay, your lip, you're gonna blow through your lips. So that's one of the things that we teach um, children or even adults sometimes when they have a stroke. And then and this will help to produce the sound accurately. Another thing I mentioned, did you say something?
Oh,
Were you
nothing.
saying something?
Oh, no.
Okay. So another thing that we work on is fluency. And that is the flow, smoothness, and timing of speech. Problems with fluency include stuttering, and that's you repeating sounds, prolongations, or blocks. So a person may say, ah, 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 or woo, 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 before they can actually get that word out. And then prolongation is you keep saying the same thing over and over before you can actually get the word out. And then they may have blocks where they have to stop and regroup and then say the word. I give an example. We were in New York, we're in Times Square, and my daughter saw this young guy. He was selling hats that said, New York City. So she wanted one of those, and we went over to ask the prices. And it literally took him like about 2 minutes just to say $2 because he had a bad stutter. I mean, eye rolling, stomping his feet. I mean, he had it really, really bad. That's what we call severe stuttering. And then they make clutter, and that is you talk too fast and you jumble your words, so that makes it unintelligible. An example that I had as well is a teenager that hesitates or repeat their syllables. So I want to go, or get stuck mid-sentence. So that's what a block would look like. We work on strategies to make speech smooth and confident. So one of the things that we would do is easy onset. So instead of attacking the word, we would say, okay, just ease into the word. We also work on breathing techniques and relaxation techniques because a lot of times when you stutter, you may be tense. And then we work on metronome. So sometimes we have them tap, or just count in their head just to help to decrease the speech rate. Another thing is voice and resonance. So we focus on how we voice sounds. So how sounds resonate through the mouth and the nose. So that's voicing. Resonance is through the mouth and the nose. Voice disorders can cause speech to sound hoarse, strained, too high or low pitched, too loud or too soft. So resonance issues can result in nasal sounding speech. So a perfect example was when I had my sinus infection and I came on and I was very nasal. Some individuals, if they the palate, the flap helps to cover to separate the nasal from the oral cavity. And if that flap is not working, then it doesn't help close off that nasal cavity. So air escapes, and then that's how that nasality is occurs. So for example, a teacher that developed vocal nodules, and that's from years of yelling over a classroom, they usually have chronic hoarseness. And not only teachers, you may see that in sports casters, coaches, pastors. So anyone where their job includes prolonged talking. And one of the things that I usually recommend is you take breaks, you take a sip of water, you rehydrate your vocal cords, and then that will help to reduce. Don't try to yell. Just try to speak at a normal volume. So what we tend to do is teach vocal hygiene, which is something I just described, breathing techniques, and exercise to restore healthy voice use. So when we look at receptive and expressive language, we are not just talking, we're just not focusing on talking. It's about understanding and expressing ideas clearly. Receptive language is understanding words, directions, and questions. So an expressive language is the ability to share your thoughts, your ideas, and your needs. So for example, a child might not understand when asked to put your backpack on the door. So that's receptive. Or they may not be able to form a full sentence to describe their day. So for example, my stepson, he has some issues with he's ADHD. So he has some issues with processing and following directions. So what we cannot give him too much information at once, because if that happens, then it won't get done. So we have to break it down into one-step directions. Finish this, then go on to this, then go on to that. If not, nothing will be completed. And another thing that I tend to do with the kids, instead of asking them, how was your day? You will get one word answer. So good. Okay. So instead of doing that, what I tend to ask is, tell me something that stood out in your day. Tell me something that made you happy today. So that forces them to use sentences or to be more expressive in their speech. So what we tend to do is help to build vocabulary, grammar, comprehension, and sentence formulation. And I also want to add that this expressive receptive language doesn't only happen with kids, it happens with individuals with stroke or dementia. And for stroke patients, we usually say it's aphasia. So that means they have difficulty producing words, or apraxia, which is more of the motor planning. So they know what they want to say, but they're not able to articulate it. So those are some things that we work on. So even though you're grown, you've had high functioning jobs, I've worked with lawyers, doctors, a different kind of profession. Once you have the stroke, then you have to relearn everything that you've known from childhood. And then hearing. Hearing is the ability to deeply connect to speech and language development. Because if you can't hear, then you're not able to produce speech sound. It's impossible. I work with a nurse, and she's hearing impaired. So and that since she was a kid. Whenever she speaks, she misarticulates sounds because she's only producing what she heard as a child. So if I hear NSD instead of Tennessee, that is what I'm going to say. We do not diagnose hearing loss. That's an audiologist's role, but what we collaborate with them closely to help clients adapt their communication if hearing is impacted. So what we tend to do is do more auditory training. So try to help them to tune in or zone into words so that they can actually hear the sound. Or we also do speech reading, which we characterize, or we sometimes say lip reading instead of speech reading. So whenever someone is communicating with them, we said make sure that person is facing you, because if their face is away from you while talking to you, it would be hard for you to hear what they're saying. Mm-hmm. So make sure that they're facing you, and ask to exaggerate those sounds, to speak slowly. So instead of saying, hey, I want you to go do this, can you go upstairs and get the pillow? So that will help with, if they're not able to hear all the sounds, they can tell from your lip movement. Oh. And the next thing, which is my favorite to work on, is swallowing. I love swallowing, and maybe it's because I love to eat, but I just think that swallowing is a social aspect of your life. That is, sitting at the table. That's where you make social connections. That's where stories are shared. That's where actual communication happens, is at the table. So we assess and treat feeding and swallowing disorders, and that's an essential life-sustaining function, because in order for us to live, we must eat. So after a stroke, an older adult might cough or choke while eating, putting them at risk for aspiration pneumonia. So after a stroke, the muscles in your oral cavity and also your pharyngeal, which is your throat muscles, they tend to weaken. So you will see individuals drooling. You will see them losing food out of their mouth. So we call it anterior spillage, because their lips are weaker, their tongue is weak, and they're not able to propel that food back. The base of the tongue may also be weakened, so it's not creating that seal at the palate. So sometimes the spillage may occur before, after, or during the swallow. And because if you think about it, the esophagus and the throat is right there. So if the epiglottis doesn't come over and close it off, the timing is slow, then the food can spill over into the airways and get into your lungs. And then that's what caused the choking. And if this keeps happening, that bacteria will build, and then we can have what is called aspiration pneumonia. And that is deadly. It could be deadly. I've had individuals that had aspiration pneumonia and survived, and I've had some that just didn't make it. And this is one of the funny things, because whenever I have a patient that needs speech, and I walk in the room and I say, hey, I introduce myself, and I said, I'm the speech language pathologist. And they said, oh, I don't need speech. And I said, yes. I said, oh, you speak fluently, so definitely not. But we work on other aspects than speech. So I go down the list of the things that we do and say, oh, yeah, I have trouble swallowing. And it's sad that a lot of individuals do not know what we do. And that's the reason why they don't get the help that they need. So I will give you a life example of a patient that I'm working with right now. So he had esophageal cancer. He had his surgery. And after that, after radiation, he had bouts of radiation. Now he cannot eat. So what do? They suck a G-tube in him, and he's had it for 2 years. So he went 2 years with his quality of life decrease because his doctor did not refer him to a speech language pathologist.
Oh, no.
He lived in Ohio, so he and his wife moved here to Tennessee. our home health agency went in to admit him and said, "Oh, I think that you would do well with a speech pathologist," and he said, "What's that? Who is that? I've never heard of a speech language pathologist." So she went ahead to explain that, hey, she can help you to eat again. And she was like, well, if that person can help me to eat again, you need to send them.
Yeah.
So I was on vacation, so another speech pathologist went and saw him and literally told him that it's been 2 years, he probably won't ever eat again, you know. So of course he was downtrodden, like, okay, he had all hopes that this person was going to help him eat again. So anyway, he was certified for 60 days, came back, went in, redid my assessment. And I told him, I said, yeah, there's a possibility that you'll be able to eat again. I said, it's been 2 years, your muscles are, weakened, because if you do not use those swollen muscles, because they're so tiny, in 3 days, they can atrophy. So that means they're weakened. And it's like you have to start over from ground zero. And he's gone 2 years without eating. So his muscles were really weak. So I said, okay, what we're going to do some exercises and help to strengthen those muscles. And then after that, we'll try to introduce, food slowly. And he was just like, oh, can you do that? And I said, it's possible, because I've seen that happen before. So I gave him, some exercises. He was very diligent. And that's the thing as well. If an individual is not diligent with completing their exercises, then their recovery process is slim, or will be slim. Because if I'm going in once or twice a week, that's not enough, because we have 7 days in the week. So I always tell my patients, it's just like working out. You go to the gym, if you go once or twice, you may see improvement over time, but it's going to take a long time. But if you're going 4 to 5 days, you will see improvement.
Yeah.
So this man said, okay, I want to eat again. That was his long-term goal, is to eat. So whatever it took short-term, he was going to do it to get to his long-term goal. Go ahead.
Well, I've had patients like that before, and I haven't really encountered a patient who had like a long-term G-tube, because usually it's contraindicated to have it for that long, especially if they're able to be, if they have the ability to be able to swallow, if it's exercise properly, as you have said. And that's fascinating to me that it took him a while. Of course, it's gonna have to build up over time. So that's wow, 2 years. Usually for us here, when I encounter patients who are who've had strokes, like the 2 weeks would be the maximum amount to have the G tube, and doctors would try to refer to a pathologist, or like what they call this, try to exercise that so that we can remove the G tube eventually, because that's the main goal of the treatment.
Yes. So usually after a stroke, but I think he was neglected, because he had cancer and he was outpatient. So I think if he was in the hospital, then his likelihood of getting speech therapy would be greater. Because if you have a stroke, you go into the hospital, they're going to refer all therapies, PT, OT, and speech. So he would have had some kind of treatment then. But it's been, I want to say it's been about 4 months that we've been working. And I'm proud to say he still has his G-tube in, but he's eating at least 1 meal a day. And he's eating it very well. The only reason why he's not doing 3 meals is because his appetite. He does not have an appetite. The what you call it? Not the chemo, but the radiation has pretty much burnt his taste buds. So food does not taste right to him anymore. Nothing is really appetizing. So pretty much he eats breakfast all the time. Like he goes I'll usually show up for lunch with him, and he wants breakfast food because the stuff on the menu, he just is not appetizing. But if he goes out to eat, then he can choose whatever he wants on the menu. The menu in the assisted living is very limited. But I saw him on Monday, and his wife was just tearing up. And she came over to me and she said, "You are so good for him." He said, "You have given him quality of life back." And as a professional, you know what that does for you?
Yeah.
It's to know that, oh, I can take someone from ground zero to 90% just so that they can function, they can socialize. Because now he can go to the restaurant with his grandkids, his daughter. He was telling me that, he had this whole thing planned out for Mother's Day. And it's just like he was looking forward to going out and eat. So that's why I'm saying it's very important. Like that's why swallowing to me is very important. And for me, like cognition, I like doing cognition. But a lot of times you're working with individuals that already have dementia, has a stroke, so they're already low functioning. So a lot of times they're not going to get back to their optimal potential. But swallowing is something that you can take someone from ground zero to 100%. So what we tend to do is recommend diet modifications. So if a person is still choking with thin liquids, we would do thickened liquids. And there are 3 different consistencies. So we have nectar consistency, we have honey, and just like it says honey, it's as thick as honey. And then we have pudding. Pudding is least recommended because to me, it's like eating applesauce. So if we don't have to do pudding, we don't. We just don't do that recommendation. I think in my whole career, I probably have preferred that probably 2 or 3 times. It's not something that I do frequently. And then if we're not able to get them back to eating, that's when we go NPO. So nothing by mouth. And I can say the only time I've done that, if I know that someone is dying, it's going to literally die if they put food in their mouth. I haven't done that a lot over the 24 years of my profession. And we also teach swallowing techniques to prevent complications. And of course, we do the exercises. And on the market now, they have VitalStim. So it's an electrical stimulation. And this has been FDA approved since 2002. And I've been using it since 2005. So a lot of times if the exercises is not doing what I wanted to do or moving the patient as quickly back to eating, then I would apply the electrical stimulation to their throat muscles, lip muscles if it's weak, cheek muscles if it's weak. And then that will give more stimulation to those weakened muscles and get that biofeedback and the strengthening that we need so that they can safely return to their swallowing.
I have a question as well. If your therapy sessions usually just it's not every day, and I'm sure some of our listeners are listening and learning more about this, what can they do? What can their family members or parents do to help continue the progress while they're at home?
I usually give home exercise program. So whatever I do in therapy, I have from day 1 or day 2, once I figure out what the patient is able to do, then I will set up a home exercise program. So I will write out everything step by step, what I want them to do so that they can continue at home. So I don't just leave them there and say, hey, figure it out. But I do set up a home exercise program. And like I said, I know who's completing these exercises versus who's not because of the way they're progressing.
That's true. What are usually exercises that are used to help the patient adapt?
Okay, so it varies. So if you're talking about, I wish I'd brought some of those in to give an example, but I'll just speak it. So if it's a weakened lips and tongue, then it's a lot of I like resistive exercises. So one of the exercises would be I would get like a spoon or a tongue depressor, hold it here. They would have to stick their tongue out, and I'll try to push it back, and they would have to resist it. If it's someone that just have a stroke, they'll have a hard time doing it. But over time, they can tell the difference. So if they're not able to do it with the resistance, I just have them stick their tongue out, side to side, up, down. They're holding it for about 3 to 5 seconds, because the goal is to fatigue those muscles so that they can build strength. And then for the pharyngeal or the throat area, we use a shaker exercise, and pretty much the person will lay flat on their back. They will keep their shoulders down and then try to hold their head up. So when they're doing that, all these muscles are tightening. And the goal is for them to hold it for 30 seconds. But depending on how weak that person is, I usually start at 10 seconds and then have them build up to 30. Sometimes my patient can even hold it for a minute. And then another thing is effortful swallow. And I always tell them, hey, we're working on swallowing. The best exercise for swallowing would be swallowing. So pretty much they would have to gather all the saliva in their mouth and put their tongue up towards their palate and squeeze and swallow hard. So I always tell them, swallow like you're swallowing a golf ball. You're trying to get a golf ball down. And usually I would say 10 to 20 repetitions based on the patient's level. Another exercise that I do for that area is they would hold their tongue. It's called the Masteko swallow. So hold your tongue between your teeth and then swallow hard. That one is pretty good too. And another one would be the jaw retraction. I'll call it the bulldog. So no, jaw protrusion. So I always tell them, just show me what a bulldog looks like. So pretty much they would jut out their lower jaw and hold it for 5 seconds. Another one would be the tongue retraction, where they keep their tongue flat and pull it back towards their throat. And that helps with the base of tongue elevation. Sometimes, just repeating sounds. So K-A, ka, 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 that works the back of your tongue. Or we do ta, 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 that works the tip of your tongue. Ga, 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 that's the back of the tongue. So it's a lot of exercises that we tend to incorporate depending on what muscles we're targeting. And a lot of times for the throat muscles, we're able to decipher those from a video swallow. So a lot of times, even after I do my assessment, I like to get a visual. So I would send them for a modified barium swallow. And then that will further tell us like what is going on. Are they pooling in their vallecular? Are they pooling in their piriform sinuses? When they're swallowing, is there things escaping? Because sometimes we can also have what is silent aspiration. And food and liquid can enter the airway, but they do not cough. And those are the ones that are real tricky, because a lot of times you don't know until they have pneumonia. So that's the reason why I like to get a visual. Okay, I deliver, I give you this food. I didn't hear any coughing, but based on my assessment, because I have a MASA, we call it the man swallowing assessment that I use, and that usually gives me a score out of 200. And based on the score, I can say, okay, this person is swallow severe, it's moderate, it's mild, or it's normal. So based on that score, I know that, okay, is it more pharyngeal, which is the throat involvement, or is it more oral? So is it the lips, the tongue, the cheeks? Sometimes they have decreased sensation in the cheeks where they pocket foods. So based on my assessment, I can, determine what exercise to give.
I see. Is that the same thing as well with speech for like especially with children who have trouble with speaking or have stuttering issues?
Yes. So with the speech, that would be a lot of oral motor exercises. So a lot of tongue, lips. So we'll tend to strengthen the back of the tongue because those are the areas that you use to produce sound. The tip of your tongue, the back of your tongue, a lot of lip involvement. So yes, we'll do a lot of oral motor exercises. For stuttering, it would be more strategies that we use. So like I said, it'll be easy onset, like just ease into the word instead of going, like they'll be like, I, be like, I. That's why I work on breathing techniques. Sometimes take a breath and just ease into it.
I see. What are some challenges though that you encounter during in your line of work, whether it's with children or with adults?
A lot of time it's non-compliance. They're not doing what they're supposed to do. Sometimes they're not understanding what we do or the purpose of the exercises, because sometimes to them it's silly. I'm sticking my tongue out, I'm moving side to side. It's silly. I don't want to do that. So a lot of time it's non-compliance.
Yeah, we deal a lot of that at the hospital as well. Like patients understand that it's for their own good, and usually either it's because they think it's silly or depression comes into play, and it's really hard to like try to help them understand. But each pathologist, how would you address that non-compliance for patients and children?
Okay, so when I have swallowing, so I'll just give an example of swallowing. So when I worked in the nursing home in rehab, I had a patient. He was non-compliant. He would do physical therapy. He would do occupational therapy, but he would not do speech therapy. So they tried 2 speech pathologists before they tried me, because they always say, oh, you always know how to get these patients to work. Because a lot of times I allow them to feel like they're the one making the decision, not me. I always put the wheel in their hand. You're in the driver's seat, you're going to drive. So this particular patient, he was tough. So I went in the room, we were talking. I didn't introduce myself as a speech pathologist. We're just talking and getting a feel of, how he's doing, how, why is he here, all that stuff. And right away, I realized that he was depressed. He wanted to be home. He didn't want to be here. And then here come this person. He wasn't eating. He wasn't doing any of that. So yeah, he was depressed. So I said, so can we make a deal? And he said, what? I said, when I leave here, I am going home and I'm going to have a scrumptious meal. No doubt about it. Why? Because I can swallow. And I said, you are being fed through a tube. That's not appetizing for you, is it? He said, no. So I said, okay, here's my deal. I said, tomorrow, you're going to come down to the therapy gym. I'm not coming to your room. You're going to come down to the therapy gym and we're going to work together. And I promise you that you'll be able to eat.
Wow.
He was like, what? So I said, yes. So I said, when I leave here, remember, I'm going home to eat. You're going to be fed through a tube. So you made that decision. And that morning, he was in the therapy gym before I even got to work. And everyone is like, what did you do? What did you say? Well, I told him that I'm going to eat regardless. He's not. So it's up to him to figure out what he wants to do. Fed through a tube, or does he want to eat by mouth? So he made that decision for himself. I want to eat by mouth, so I'm going to do this. And he was able to eat in a couple months.
Well, that
doesn't work for everyone, though. But so that was a success. But for the most part, I think I have a lot of success with my patients.
Wow, that's
even
amazing.
if I walk into the room or into their home or whatever, wherever I go to see them, and initially they say, oh, I don't need speech. But after talking to them and after finishing my assessment, sometimes they need it, sometimes they don't. And the ones that don't need it, when I'm finished, and I said, well, you were right. You don't need to see me. Why? Why aren't you going to come back? I want you to come back. And I said, well, you don't need me. So yeah. So usually by the time I'm finished with them, they always want me to come back. Very few, like I said, just stays defiant.
Yeah, that's the thing. If you like with when you say speech language pathologist, it's just they think it's of one thing, just about speech, and
Exactly.
other things that you actually do, and
Exactly.
them about what you do. It really helps them understand and see that, from their perspective, that they actually need what, your services. So
Hmm.
usually happens when during a speech therapy session, what do you usually do whenever you sit down with a patient?
Um, so usually you break the ice. So I'll go in, I'll introduce myself, and then just say, "Hey, tell me a little about yourself. Tell me why do you think you need speech therapy?" Some of them, they know they had a stroke, they're not able to communicate. Some of them know, okay, I have a G tube, I can't swallow, or I'm coughing, choking. Others, they have no clue why they need speech therapy because cognitively they're not intact. And so after I break the ice, then I said, I'm going to do an assessment, whether it's cognitive, speech, or swallowing. And just to get a baseline, it's not pass or fail, because whenever they hear test, they're thinking that, oh my goodness, you're going to take me out of my home, or I'm not going to go home. And I said, it's
Mhm.
not pass or fail. It's just for me to get a baseline to see what's going on, where you're at, and then to see how I can help you to get to where you want to be. And then a lot of times you're like, okay, and after I do the assessment based on their scores, so a lot of times for cognition, and that's the next thing I was going to talk about, I would give the slums, and pretty much it covers memory, problem solving, organization, so word finding, and orientation. So I will go through, it's like a 10 questions. I'll go through that and based on their score. So I always, when I get to the end, everyone wants to know, okay, what does my score mean? So I would explain from one to, if you get a score from 1 to 20, that means you're in the dementia range. Oh my gosh, I have dementia. Nope, I do not diagnose dementia, but I do recommend further testing with the neurologist, and then they can decide whether or not you have dementia. So then that makes them comfortable because, oh no, this woman come in my house trying to diagnose me with dementia. And then from 21 to like 26, that's the mild neurocognitive range. So,
Mhm.
from it's a wide range. So normally I break it down mild to mild and mild. And then from 27 to 30, that is the normal range. Everyone wants to be normal. Everyone wants to
Yeah.
be normal. So that's the thing. Oh, so what can I do to get to at least 27? Oh, you got to work with me. And
Mhm.
then in 4 weeks, I'll retest you, and then we can compare the scores. Sometimes people go up, sometimes they stay the same, sometimes they decline, depending on the day and what's going on. Because I had a patient I discharged today. Her baseline when I did the assessment was a 22, but she has a lot of psychiatric issues, and she also has seizures, which impact your memory. So when I redid it, when I reassessed her in 4 weeks, she scored
Mhm.
an 18. When I reassessed her 4 weeks later, she went up 1 point. I reassessed her today and she was back at baseline, which was 22. So she was happy.
That's good.
Yeah.
Wow. Good to have like to set goals with your patients so that they'll be able to,
Yeah,
see the results eventually and have
exactly.
that. Yeah, that's good. That's really amazing. So there
And
was a question a while ago by one of the comments. They were asking if do all stroke patients get speech therapy, or if it's just as needed.
it depends on how severe the stroke is. Like if someone has, and it depends on what area of the brain is affected. So it depends on the severity and the area of the brain that's affected. Like I always say, language is going to be affected if the left side of the brain is affected. You probably have more memory and all that stuff if it's the right side, more spatial things. So no, not all patients require speech therapy after a stroke. A
That's
lot of
good.
times they will need some physical therapy just to help with strengthening, but not all of them warrant speech therapy.
And another question here is does everyone who does not pronounce words properly needs speech therapy?
It depends on their age. And like I said, it also depends if they have a hearing loss. So there, I think up to age 5, like misarticulation on certain words is okay. But beyond that, then there is a problem somewhere. So definitely get them checked out by a speech pathologist.
I see. So for me, I've encountered a lot of family members who have struggled with, especially if they're better, they're usually not sent to they're usually not staying longer in the hospital. They're sent home, and a lot of our family members would usually ask like how they would help their patients. So do you know any support groups that you could recommend or resources that those family members can find to be able to help their patients or their children?
Oh, sure. So if you would just go on Google and whatever issue is going on, exercises for lips or tongue or cheeks, tons of exercise will come up. Our exercises for swallowing, tons of exercise will come up. Exercise for cognition. And then I will also put some in the chat after I get off. I can probably upload a few just so that you have it there. But definitely on Facebook, they have the stroke recovery groups. They have swallowing groups. Because I know a lot of people are on social media, so that would be easy access for them. It's just to go on there, and there are tons of groups on there. I mean, I'm on this traumatic brain injury group, stroke group, dysphagia with a swallowing group. So yes, so I mean, social media makes it so easy for those support groups.
Yeah, that's true. Because especially here in the Philippines, a lot of our patients can afford to continually be in therapy, and it's really nice to know that we can find resources online,
Yeah.
especially some money to be able to.
Yeah, there are tons of resources online. Okay, so I'm going to go into the cognitive aspects of communication. And I covered, I glazed over it earlier, that we covered thinking skills that support communication. There's memory, attention, problem solving, organization, and reasoning. An example, a person recovering from traumatic brain injury struggles to stay on topic or organize their thoughts. And we work on rebuilding these cognitive communication skills for everyday life and independence. And I gave the example of my patient with the cognitive issue following a stroke. And there's also social aspects of communication, and we call that pragmatics. So effective communication is not just about words, it's about knowing the social rules of communication. So for example, a child with autism may not understand personal space. So you're doing something and they will come right up under you trying to do the same thing. Or you're talking and they're in your face talking, not knowing that that's not appropriate. They might interrupt frequently. So you're having a conversation here, and the next thing, here they come and just start talking without saying, excuse me. Or they struggle with making appropriate eye contact. So what we teach is turn taking. Okay, so I'll talk, you talk. When you're finished, okay, so you practice turn taking. And it's intentional. So you will stop and say, okay, it's my turn. And then eventually they'll get used to, okay, I have to let this person finish and then I can talk. Interpreting facial expressions. So I wear my expressions on my face. I don't know how to not do that, because even my patients, whenever they're doing something and it's wrong, they always look at my face and be like, uh-oh, that was wrong, wasn't it? I don't know how to not wear my expressions on my face. And these children doesn't know how to interpret it, or if you have traumatic brain injury, it's hard for you to interpret those facial expressions. what it means. They use inappropriate tones. So pretty much they might be too loud and just make noise. And that's not normal. And it becomes irritating to whoever is in that atmosphere. They do not understand sarcasm or humor. So everything is taken personal. And then the last thing was the communication modalities. And that is when verbal communication is difficult or impossible. So pretty much is the last resort for us. This could be a low-tech device like picture boards, writing notes, or it could be a high-tech device, speech-generating devices or apps. And I will give an example of a patient that I just discharged. He's 35 years old, young guy. He's a paraplegic. He injured himself while he was wrestling, and he ended up having a stroke. So that affected his speech. So he wasn't able to express his wants or needs fluently. This again happened 2 years ago. And one of our nurses went in, saw this patient, and recommended him. I went in. I was able to get him a communication device. The mom, the caregiver, everyone is happy because now when he cannot say what he's trying to say, he can touch that icon and it can speak for him. So I inputted his whole history, what happened, what caused him to be paraplegic, all his medications, his diagnosis, everything about him, the restaurants that he liked to eat, places he liked to shop. He touched it. No one has to guess what he wants to do. It's right there. So some of the common myths about speech therapy that I mentioned earlier, I'm going to take a moment to break down a few of them. So one, speech therapy is only for kids. It is true that many children benefit from speech therapy, but based on what I said, adults need speech therapy just as much sometimes. So think about someone recovering from a stroke who suddenly can't find the words to speak clearly. An adult with Parkinson's disease who begins to experience slurred speech and difficulty swallowing. Then the SLP will help adults regain communication functions like memory and attention, even learning how to eat safely from rehabilitation to end-of-life care. Their support is often a game changer for adults and seniors. So we are needed by adults. Yeah. If you can talk, you don't need speech therapy. This one is sneaky. Just because someone can talk doesn't mean they're communicating effectively. They might struggle to find words, miss the point in conversation, so that's their processing, or have trouble expressing themselves under stress, aphasia. Like I said earlier, some people may speak fluently, but can't understand what others are saying or having difficulty reading and writing. And that's usually occur in dementia as well. So SLP don't just work on how things sound, they support how communication flows. They help people feel understood and empowered, not just audible. And then the last one is SLPs only work on speech. Nope, not even close. Speech language pathologists are trained in swallowing therapy, which is critical for patients who've had stroke, cancer treatments, or neurological conditions such as dementia and Parkinson's. They help individuals relearn how to eat and drink safely, reducing choking risk, preventing aspiration pneumonia, and restoring a sense of normalcy and joy around meals.
Oh, wow. It's a mirage, wholesome.
Yes.
Therapy.
Yes.
Wholesome.
Yep. So we address social skills, cognitive decline, voice therapy, and so SLP help these individuals not just to return to daily life, but to thrive in it. So that's our job. We want people to have quality of life, so we're going to do whatever it takes to get them back to it. And I just want you all to know that we are a necessary component. Speech pathologists, we are necessary. So a doctor cannot do what we do. Yeah, just like how they refer you to a surgeon. So you have individuals that have specific roles. That's our role. So a doctor cannot return you back to normal swallowing. A doctor cannot help you talk better. So we are the ones that are more than happy to have you, to return you back to your quality of life. So in conclusion, I want to add that when most people think of speech therapy, they picture helping someone to talk better. But as we explore today, communication is complex, and so is the work of speech language pathologists. The big nine that I mentioned earlier reminds us that SLP don't just only help people speak, they help them connect, understand, express, think, socialize, eat, and live fully. From a toddler learning their first words to a senior relearning how to swallow safely after a stroke. Speech therapy touches every corner of life where communication and connection matters.
Wow. Thank you so much for helping us understand.
Oh, absolutely. Absolutely. And thanks for tuning in to My Mess Became My Message. If you found this information helpful, share it with someone who might need to hear it. And as always, let's keep learning, growing, healing, and talking about the things that matter. Stay connected, stay hopeful, and remember your voice, your mind, your story, they all matter. So please tune in next week as we delve into the topic misdiagnosis of dialect speakers. You do not want to miss it. Until next time, be safe and blessings.